Welcome to the first of four webinars in this series entitled Designing for Behavior Change, a Human-Centered Approach to Research and Intervention. This series of webinars is brought to you by the Human-Centered Design Task Force of the American Heart Association's Healthcare by Food initiative, and is part of the initiative's cooperative studies model designed to foster shared learning and innovation across the Healthcare by Food initiative. Before we get started, I need to share this important disclaimer. Statements, opinions, and study results presented in this presentation may not reflect the policy or science position of the American Heart Association unless otherwise noted. My name is Stacy Chang, and I'll be hosting the first and fourth webinars in the series, and my colleague Natalie Pervet will be hosting the second and third webinars. Together, Natalie and I, along with some of our colleagues, have embedded human-centered design as a guiding component of the Healthcare by Food initiative. The guidance and learnings from these efforts are captured in these webinars, and our hope is that they will prove useful in the design and execution of your studies as well. I won't go into detail about our backgrounds, but our bios and contact information can be found at the end of the deck that accompanies this webinar. This series of webinars has three overall learning objectives. The first is to understand and apply human-centered design principles and the COM-B behavior change model to research and interventions. The second is to use journey mapping and persona tools to analyze user experiences and to identify critical behaviors across the food as medicine journey. The third objective is to design targeted interventions by integrating insights from human-centered design tools and behavior change models to inform your research strategy and approach. Although some previous studies have applied these principles, models, and tools to research studies or protocols already in progress, we find these tools potentially have more utility early in the process as you're developing and defining your study. This first webinar, Foundations of Human-Centered Design and Behavior Change, will introduce the principles of human-centered design and systems design, as well as introduce you to the COM-B model of behavior change and help you to differentiate between systemic and individual interventions that you might apply in your studies. Subsequently, the second webinar will introduce a journey tool and how to apply that to your food as medicine study. The third webinar will combine the COM-B model with journey mapping to identify behaviors critical to the success of your study. And the fourth webinar will introduce a personas tool to the mix to help generate additional actionable insights to inform your research strategy. As I mentioned earlier, this first webinar will focus on the foundations of human-centered design and systems design in pursuit of large-scale behavior change. In this session, we'll introduce the key concepts and application of human-centered design and systems design. We'll also introduce the COM-B model of behavior change, which is a human-centered framework that can be applied to your research. Lastly, we'll differentiate between systemic and individual interventions and examine the characteristics and implications of each approach for designing study interventions. Broadly, at the highest programmatic level, we are using human-centered design to better understand current behavior of individuals who are contending with new changes in food consumption. If you're not familiar with GusNIP, it's a federal program that provides funding for projects that increase the purchase and consumption of fruits and vegetables by low-income consumers. The most surprising statistic is that even when provided vouchers for free food, only about 65% of those vouchers are actually redeemed. Clearly, if the provision of free food is not enough to anchor changes in food consumption, some other influential factors are at play. Part of the aim of the research component of the Healthcare by Food initiative is to conduct rapid cycle iterative testing in contexts where they could be broadly implemented to increase engagement. For those of you who are familiar with human-centered design, you'll recognize the double diamond diagram here, adapted by Kevin Volp from the Design Council's well-known illustration. Kevin is the scientific lead for the Healthcare by Food initiative, and he uses this illustration to describe the broader strategic approach to the design of clinical research. The aim is to gain human insight through contextual research, to define the critical problems that need to be solved, and to identify the metrics that will indicate meaningful shifts, and then to explore multiple directions using small-scale experiments to test solutions and to learn what should then be implemented at scale. For those of you who are less familiar with human-centered design, part of the goal of this first webinar is to give you a foundational introduction to the field. When most people think about design, they think of a practice of aesthetics, things like interior design, which might result in a beautiful environment which you might want to dwell. Or they think of reality TV shows like Project Runway, where fashion designers create outfits we admire and want to wear. In truth, though, design is much more than the practice of aesthetics. Surely, the final output of a design effort might result in something beautiful to look at or to wear, but design is much more about the process of understanding human needs in order to develop something that then solves those needs and is easy and rewarding to use. To quote the inimitable Steve Jobs, it's not just what it looks like and feels like, design is about how it works. If you corner any experienced designer, eventually they'll sketch something that looks like this on a napkin for you. Ultimately, if innovation is the goal in whatever endeavor and industry you're in pursuit of, then you actually have to consider three overlapping demands or factors that contribute to a truly innovative offering. Innovation requires you to consider feasibility, often enabled by technical or technological capabilities. It also requires you to consider viability because you won't have any impact if your offering can't survive in the marketplace. But ultimately, it has to be desirable. It has to be something humans want and can use. Silicon Valley, as an example, is a graveyard of great ideas where someone thought, oh, if I build it, they will come. And then nobody ever came for a product that was only about a technological breakthrough, absent any consideration of human desire for that technology. So we always begin with desirability, and that means understanding, first and foremost, the needs and desires of the humans we're serving. There are plenty of great stories from the annals of history that make this point quite illustratively. Exubera from the mid 2000s is a classic case study. Pfizer had bought the rights to inhalable insulin, thinking it would be the grand breakthrough that would finally free diabetics from the need to use needles. Instead, they designed a device that they expected people to use in daily life, just as in this marketing image, in a crowded cafe or in another public venue that amounted to breaking out the equivalent of what looks like a medical bong and then taking a hit in the middle of a restaurant. It's no wonder they wrote off nearly $3 billion in investment while saying, as you see here, that Exuber has failed to gain the acceptance of patients and physicians. The critical insight that they had forgotten was that insulin needles, no matter how daunting to use, were, at the very least, a discreet means for a diabetes patient to dose their insulin and didn't advertise to the world that they were diabetic. Stigma, and therefore discretion, are still very real human concerns in the management of chronic disease. Conversely, we have this case study from Bayer, specifically the design of their blood glucose meters. Bayer had been the first to bring consumer blood glucose meters to market, but a generation in, Bayer's products had become undifferentiated in the marketplace as competitors introduced similar products. Not too different from Exuber's inhaler, Bayer's original line of blood glucose meters for diabetics looked and behaved exactly the way you would expect a medical device to. It's designed to take a test strip and analyze blood sugar levels to help a diabetic determine insulin dosing. The user interface was designed as a function first scientific instrument with little consideration for the situation in which a patient would use it, and with the usual blue and white color scheme that just screams, I am a medical device. Frustratingly, while motivated users used the device effectively, the drop off in use by most users was severe, a symptom of the broader challenge of keeping diabetics engaged with their own self management. Motivated by their dwindling market share and lack of user engagement, Bayer embarked on a redesign of their blood glucose meters. Through design research, there arose two critical insights. First, like Exubera, patients with diabetes didn't like advertising that they had a chronic disease. Pulling a medical device out of your pocket at work or at meals or in public made them self conscious, and they would often skip measuring their blood sugars to the obvious detriment of their diabetes management. Secondly, and more importantly, it wasn't obvious to most users how their own behaviors affected their blood sugar. So users found the significant variations in their blood sugar levels confounding, unpredictable, hard to manage, and ultimately very discouraging. Bayer's redesign of their blood glucose meter looked fundamentally different than its predecessor. Instead of screaming medical device, it adopted visual design cues from consumer electronics, looking more like a sleek black USB storage stick than a medical device. Even the digital interface utilized a backlit LED display instead of the usual low end liquid crystal display, with the overarching goal of having the device blend in with the other consumer electronics a regular human might carry in their pockets, and less like a signal to the world that the carrier was a diabetes patient. The bigger innovation, though, was in the design of the interaction. Typically, when you use a blood glucose meter, you have to wait several seconds to register a reading. During that time, the patient is a captive audience, usually just twiddling their thumbs waiting for the result. When Bayer redesigned the interaction, it utilized the momentary downtime to ask the patient to record a few things like, are you taking this measurement before or after a meal? Have you exercised recently and how much? The questions took a few button pushes to answer and then were stored on the device before the blood sugar level reading was displayed, and then the user would carry on with their life. However, this battery-powered device needed to be periodically recharged, and then when it was inevitably plugged into a computer to charge, it would launch a program to show the patients their own trends in their blood sugar levels and mark where their meals and exercise occurred. And for most patients, this was the first time they saw definitively how their own behavior correlated and affected the trajectory of their disease. Subsequent variations connected wirelessly via apps, but the insight provided was the same. The new blood glucose meter was a huge success, so much so that it became the specified companion for Medtronic's insulin pump, explicitly because of the effect it had on patient engagement and learning. Gathering deep insight into the needs of the humans who are at the core of your audience is the starting point for human-centered design. This double diamond diagram characterizes some of the fundamental principles behind human-centered design. It begins with discovery, which is in-depth research using sociological and psychological approaches to understand what people really care about. That discovery is divergent. We don't prescribe boundary conditions on what can be discussed. Instead, we allow people to lead us to their topics of concern. Those insights help define areas to focus on based on people's needs. Giving definition to these focus areas is a convergent exercise, which leads to a higher resolution definition of the problem to be solved. At this point, we then begin to develop solutions, pursuing an expansive and experimental approach. It's another exercise in divergent thinking. Those prototypes, which test different aspects of the final solution, are meant to refine our understanding of the user's needs as much as they are meant to trial answers to the problems we had earlier defined. What we learn from those experiments is then combined in a convergent effort towards an integrated, deployable solution at scale. One of the key aspects of the design research that is conducted at the beginning of this double diamond diagram is the idea of getting behind the veneer of any individual human. Traditional market research, including survey mechanisms and prescribed interviews, only get you the answers to the questions you know to ask. You observe what people do, you can record what they say, but it's relatively hard to penetrate that individual human veneer of politeness and formality and to actually understand how they think and feel. In human-centered design research, we deploy psychological and sociological techniques to understand more what lies behind the veneer so that we can understand how they think and how they feel, so that we can begin to understand the needs that people are unwilling to speak about or are even unaware of. In design research, we often repeat these tacit truths. People do not always do what they say they do. People do not always do what they think they do. People can't always do what you think they do. And people cannot always tell you what they need. This picture was taken as part of a research project studying eating and nutrition habits. This woman struggled to manage her weight, but insisted that she ate a very strict, healthy diet with great intention. Taken at face value, what she said she did wouldn't actually make much sense given her health and fitness challenges. So instead of accepting her answer and moving on, we instead shadowed her for a day in the life of her office work. What we discovered was that as she went about her daily office tasks, she'd visit the receptionist and help herself to the candy bowl, or grab a leftover pastry in the break room, or partake of refreshments during her team meetings. What she's showing us in this photo was a can of Nutella that she'd forgotten about and then found in her desk drawer when we asked her to show us the contents of it. And it was something that she'd kept around just in case she got hungry, but didn't register as part of her intentional eating plan. It's important to note that it's not that she had intentionally lied to us about her eating behaviors. It's that she was unaware of her own unconscious eating habits. This woman is a classic example of someone who does not do what she thinks she does and can't describe what she actually does. Another amazing example of unconscious behavior is captured in this photo. This photo was taken as part of a project studying medication adherence in elderly individuals with arthritis. You can see the evidence of arthritis in her hands in this photo. When we initially asked this woman if she had any trouble taking her medication, she said, "No, I have no problems at all." Looking at her hands, we did wonder how she managed to open the medication vials, which were small and very tightly capped. When we asked her to show us how she opened the medication bottles, she led us to the kitchen, turned on her bread slicer, and promptly sliced the tops off the medication bottles. When we marveled at her ingenious solution for managing the difficult to access bottles and asked why she hadn't told us when we uh, uh, first questioned her, she said, uh, "You asked me if I had any trouble opening the bottles, and I don't." She had devised her own solution, but was in every way an outlier in how she did it. If we hadn't delved more deeply, we might have assumed that the medication packaging was sufficiently accessible, which in hindsight it clearly wasn't. This case study of the woman accessing her medication bottles illustrates the notion we often pursue in our research in human centered design that we call extremes. It begins with an appreciation that while oftentimes our target audience is best defined as the middle of the bell curve because that's where the bulk of the audience resides, it's useful and sometimes even necessary to look at the extremes of that bell curve, not because you're necessarily targeting the needs of the extremes on whatever variable you might be considering, but because individuals at the ends of the bell curve magnify the needs that those of us in the middle of the bell curve actually have, but are harder to discern because they're not particularly amplified in the average middle. Let me explain with an example. Years ago, in a project at IDEO where I used to work, Birkenstock had asked us to do some research for the next generation shoe that they were designing. When we identified the individuals we wanted to interview as part of something we called an unfocused group, we actually invited three participants. The first participant was a podiatrist by trade. She could explain in great detail the biomechanical issues and challenges that different foot structures presented, things like supination or pronation or metatarsal pads. She was certainly an extreme because of her depth of knowledge around foot anatomy, but it's not as if every one of us, when we're shopping for shoes, doesn't evaluate the same things that she does, just without the depth of expertise or the language to describe it. We try on a pair of shoes, walk twice around the store, and decide if they're comfortable. Now, we can't describe what biomechanical aspects actually makes a shoe comfortable, but we do know when the shoe feels comfortable. In this case, the podiatrist could reflect the need for comfort, which exists in the middle of the bell curve, but describe it in ways that were beneficial to us as designers as we pursued different ways to achieve comfort. The second person we recruited for this unfocused group was a hippie who lived in Berkeley, California, and didn't wear shoes in her daily life. You might ask, why would you interview someone who doesn't wear shoes when you're working on a project to design shoes? What we learned from this woman was a reminder of all the things shoes do to protect our feet every day, because she, in not wearing shoes, had devised all sorts of solutions for protecting her feet in daily life. She'd wrap them in cloth when she knew she was going out to walk on rough pavement. She'd insulate them for when it was cold out. She reminded us of all the things that shoes do to protect our feet from the environment and provided fresh inspiration for how to improve shoe function from the experience that she had had from not wearing shoes. The third person we recruited might be a little unexpected in that we recruited someone with a sexual foot fetish. Why would we do that? The answer is because the sexual foot fetishist has an extraordinarily and maybe uncomfortable emotional connection to feet. Now, while we certainly weren't designing for foot fetishists, every one of us in a shoe store tries on a pair of shoes and evaluates how they look aesthetically. Do these shoes make my ankles look fat? Do they work with wide leg pants? How about with or without socks? We all have an emotional connection to how our feet look in different pairs of shoes and with different outfits, and we make that evaluation almost unconsciously. What the sexual foot fetishist gave us was a deeper understanding of what makes a foot beautiful, and language described that emotional response. the curve of the arch of the foot, the proportion of the toes to the foot overall, and plenty of other mildly uncomfortable things. Now, while it's a bit amusing to consider the point of view of a sexual foot fetishist, their extreme perspective gave us a deeper understanding what makes a shoe universally attractive and therefore more likely a market success. Each of these individuals in this unfocused group represented an extreme on different variables, but each of them also represented a need all of us in the middle of the bell curve also care about. They just happen to present those needs in much starker contrast, so they're easy to see and to express. And they could talk about them in much more sophisticated ways to help us better serve the needs of the middle of the bell curve. The same is true for the populations that you serve. No population is monolithic, consisting of a cohort of identical people. There is meaningful variation in the people you're designing for, and appreciating that variation will help you design more effectively for broad uptake and positive outcomes. Which brings us to the first exercise in this webinar. Take a moment, you can pause this recording and consider these questions for the study that you're designing or conducting. Who are your typical users? This is a question you've probably already have an answer for, but also who are the extreme versions of your users? Spend a little bit of time and consider where variation across your bell curve might actually provide insight about how to design for the middle of your bell curve. As you identify what extreme means to you, consider in what ways these individuals are extreme. Are they extreme in a classic demographic way, something that we typically consider? Or are they behaviorally or attitudinally different? Do they have different kinds of expertise? Do they exist in different circumstances that might affect their uptake or willingness to participate in the study that you're designing? After you've considered these questions, resume this recording and we'll move on to the next topic. Welcome back. We're going to talk a little bit about design and areas of practice. Design comes in a lot of flavors. You can design products and interfaces with them. You can design the environments in which we live, work, and play. You can design communications in both the narrative and the visual sense. Service models and interactions are designed, and so are organizations and the way they function. And at the most complex level, we can design systems, shaping the way stakeholders interact and induce change or maintain status quo in the functions of that system. In the case of food as medicine, several of these flavors of design are relevant. Food, in the form of medically tailored meals, are products, including the technology interfaces we might utilize to order them or to record healthy behaviors. Food as medicine is definitely a service in the protocols with which we engage people in diagnosis and intervention, including education and delivery of meals. How we communicate with patients matters in the language we use to guide them through disease management and in the way we introduce new health behaviors into their lives. And food as medicine is definitely a system that consists of researchers and healthcare professionals, the food industry, payers, policymakers, technologists, amongst many others, all of whom have to work in concert for food as medicine to succeed at scale. And that brings us to a discussion of systems design, a conversation that has been central to the Healthcare by Food initiative in deference to all the stakeholders I just mentioned who have a material role in realizing food as medicine at scale. Understanding at greater depth the entirety of the system in which we're doing research helps us understand how to better design our experiments to shift the system at scale. It's useful to start with a definition of complex adaptive systems, of which food as medicine is definitely one. We all tacitly know very few of our most difficult modern challenges actually can be solved in silos or with point solutions. Our biggest challenges are actually those of a systemic nature that involve many stakeholders that work alongside each other according to their own incentives, sometimes in cooperation, oftentimes in competition. Socially constructed systems like food and healthcare are non-deterministic. That is, you can't prescribe a logical algorithm that accurately describes the system's behavior, then unleash it in the wild and expect stakeholders to abide by it. That doesn't work because these distributed stakeholders don't answer to a single authority, and because the system's outcomes emerge from the dynamic interplay between inherently unpredictable stakeholders. Why are they unpredictable? because organizations are led by humans who aren't perfectly logical. They have bias and emotion. They respond to incentives, including market incentives, to benefit themselves. Solving for complex system problems therefore requires different tools and approaches. One of the most critical necessities in the design of systems is a clear and honest characterization of how the system is actually constructed and how it actually behaves, instead of how stakeholders think it behaves. In work I did starting a decade ago to develop an exemplar for a regional value-based healthcare system in the US, one of the first things we asked stakeholders in Central Texas was, how does the current system as a whole fund and deliver care to the residents of the region? Guess how many people knew the answer to that? That's right, zero. So we set about characterizing the system, including all of the funders, care delivery organizations, the population served, the administrative and governance oversight, and all the exchanges made between the entities in order for the system to operate as it did. What emerged was a map of a very convoluted system that a local leader aptly described as not a system anyone would intentionally design. And that statement is a critical insight into complex adaptive systems, which is that while their genesis might have had a rational basis around some exchange of value between stakeholders, that they eventually evolve and morph into a really tortuous set of interactions that no one in their right mind would actually prescribe. But because it evolved organically over time, legacy structures remain. They get preserved, and new capabilities are layered on top to respond to ever-changing demands. And then you end up with something that looks mostly irrational and illogical, but yet somehow manages to achieve its aims. Sometimes barely, and actually sometimes not at all. We did a similar exercise with Gavi, which is the Global Alliance for Vaccines and Immunization, in an effort to help develop their fifth five-year strategy in 2019 and 2020. A focus of the work was to characterize the grant process for determining and deploying aid to the countries in need of vaccine assistance. What you see here is a map of the current state of their grant portfolio management process, from the beginning where application through to review and approval of those applications and the deployment of funding and reporting back on results. When they saw this map for the first time, Gavi was really surprised to come to terms with the spaghetti diagram, including things that worked in ways they had never intended. Reconciling the flurry of activity in different parts of the map, you could actually identify the critical set of system functions that each collection of exchanges was meant to achieve. It was hard to divine if you only examined the trees in the forest instead of the forest from an elevated view, which is what we did with this mapping. Importantly, once the system function became clear, you could then immediately identify redundancies in the system, characterized in orange here. For example, countries who had been long-term multi-year recipients of aid from Gavi were already very well known to Gavi. Collecting data from years of monitoring and close working relationships meant that things like reconnaissance to form the next year's application for aid were completely unnecessary. And in fact, the application in its entirety was largely redundant for those countries who were already on the cusp of independence from that aid. One of the other unique characteristics of complex adaptive systems is the presence of what we call emergent properties. They are properties, usually unwanted, that arise from the interplay between stakeholders. Emergent properties are characteristics that no stakeholder wants or even planned for, but nonetheless affects the system's functions and every stakeholder inside it. So what you see in front of you is a characterization of stakeholders in the usual fee-for-service US healthcare system. At the center of this map are three of the most critical stakeholders: the patient, the physicians who care for them, and the payer who pays for and intermediates that value exchange. Because physicians are the only ones who can bill payers in the system and therefore unlock money flow, their time is critically valuable. No downtime is tolerated because it means lost revenue. Physicians therefore require a steady flow of uninterrupted patients, and any gap in that supply of uninterrupted patients is lost revenue. So what do? We institute waiting rooms. where we assure an ample supply of patients at all times so that as soon as a physician is ready, the next patient can be brought in. That same dynamic across scale creates waiting in the system, waiting for appointments, waiting at the clinic, waiting for diagnostics, waiting for test results, waiting for treatment. Waiting is an emergent property of the system and a deeply frustrating one for patients, for whom the delay can be actually dangerous, but also almost always disappointing. And subconsciously reveals to the patient that waiting is a result of the care delivery system putting its priorities over the needs and desires of the patient. This conflict is a collision in the system, noted right here with the orange diamond, in the exchange between patient and physician. We see emergent properties in every complex system in society. A classic example is pollution in the automotive industry. Nobody, the car manufacturers, the consumers, or the petroleum suppliers, actually wants to dirty the environment. But pollution emerges when these stakeholders combine to mobilize the society using internal combustion engines. And that is now an existential threat for us, which we might finally be making real progress on with the advent of electric cars. What's an emergent property in our food industry? Interestingly, the rise of shelf-stable, delicious, inexpensive food that supplies very little in the way of nourishment, essentially calories without nutrients. It wasn't the original goal of food producers to produce food that wasn't nourishing, quite the opposite, actually. But market dynamics, consumer preference, and the cost of supplying fresh food, especially in places far from the growing fields, means that a lot of processed food is now available to the consumer at low cost, but with significant negative health impact. The last fundamental tenet of systems design I'll describe here is system leverage for change. When you're trying to act on a system to change its behaviors or modify its functions, you have options for how to intervene. This illustration is actually from a project we were working on to improve transitions in care when patients move between care institutions, from a hospital to a nursing home, for example, and how we might improve them. What's most important is the column on the left that distinguishes between levers that at the bottom have very limited impact but are easy to change. Things like parameters, metrics, and materials. Here, changing how and what you measure in a system often emphasizes what matters most. In the middle are things like feedback, controls, and delays, which affect how elements in the system interact and how fast. Above that are power, governance, and structures, which define the rules for how system behaves. And then at the very top, you have things like intent, mental models, and culture, which have a huge impact but are extraordinarily difficult to change at a system level. These levers essentially define what the system is designed to do and how you shape the direction of the system. And as you consider the interventions you're researching, it's useful to consider what in the system you're trying to change and what mechanisms for leverage are at your disposal. All this brings us to a map of the food as medicine ecosystem, developed for and by a national convening of food as medicine stakeholders. Brought together in New York City in the fall of 2024 by the American Heart Association's Healthcare by Food initiative, this convening was designed to consider what systemic efforts were needed to realize food as medicine at scale. The base version of this map, which you see here, includes the major categories of stakeholders, with more specific types of entities called out within them. The primary stakeholders are the community, which includes patients and their friends and family, on the right, the healthcare industry that provides care for them on the left, and in the middle, the entities, both commercial and nonprofit, who are involved in the production, delivery, and support of food as medicine offerings. Above that, in the middle, you have payers who fund that exchange, including employers, commercial insurance, government, and sometimes philanthropy. And then finally, in the gray boxes surrounding these fields, you find stakeholders in gray, policy, research, regulators, public health, and technology. They all play influential roles in setting rules, developing evidence, enforcing, communicating, and enabling the broader food as medicine system. The fundamental transaction in this system is the diagnosis and therapeutic plan that a physician develops for a patient in need, and the prescription and then delivery of a food as medicine intervention, in this case characterized as a medically tailored meal, MTM. This is obviously a simplified characterization of this fundamental transaction because each exchange might require numerous stakeholders to realize, but it is the essential function of the system, which is delivery of the food as medicine intervention. Of course, there's a payment or reimbursement system function that enables the fundamental exchange. I probably don't need to describe the convoluted way in which we fund our healthcare systems in the US, but you will recognize payment from individuals either through a deduction from their wages through their employers or through taxes through the government that eventually reimburse both the healthcare provider and the food as medicine provider for their products and services. Slightly less obvious is the system function characterized here in blue, and that is the realization of value. While the provision of a medically tailored meal prescribed by a physician, delivered by a meal provider, and paid for by a payer completes the transaction process, it actually needs to generate value, usually measured in health outcomes, in order for it to continue or to scale. If value isn't produced in positive health outcomes, then the transaction will eventually cease because it has no value. These three system functions illustrated here are really at the core of the food as medicine ecosystem and the most obvious functions of the system. If you push deeper, there are many more detailed and nuanced system functions that support these three overarching system functions. It was these detailed and nuanced system functions that the convening in the fall of 2024 considered. Um, we had representatives from academia, policy, social services, industry, the public sector, and healthcare. And the attendees collaborated in focus work groups to define the systemic challenges facing food as medicine, to identify pathways for response, and to devise strategies for advancing the field. These clusters of challenges identify where the working groups believe the biggest gaps in the system reside, or where stakeholder interests overlap. Building effective responses to these clusters will require careful consideration of stakeholder incentives as well as coordinated and collaborative action. Simultaneously reveal multiple pathways to success. This first system map helped us to shape a view of where the system challenges lie, identify response pathways, uh, and, and helps us develop effective system solutions, all of which is the work that lies ahead of us, including what you may be working on. This brings us to our second exercise for the session. Take some time to consider what stakeholders your planned study includes and what exchanges you hope they will make and the nature of the evidence you're trying to collect about those exchanges. You'll find a PDF of this stakeholder map and assets included with this webinar. Feel free to pause the recording while you work on the worksheet and then come back and resume the recording when you're ready. Welcome back. If we recognize that a major tenet of food as medicine is the required behavior change for people to shift to healthier eating habits, then it's useful to have a framework to think about this. The framework we've used in food as medicine is the COM-B framework originally developed by Susan Michie. You're welcome to investigate her research further, but I'll describe her COM-B model briefly here. The COM-B model, which provides a framework for understanding how behavior change arises from a combination of capability, opportunity, and motivation, describes how these three factors interact in order to enable an individual to change their behavior, and how interventions can be designed to increase any combinations of these factors to activate behavior change. In food as medicine, the influence of these three factors is quite evident. Capabilities include the necessary knowledge and skills, such as nutrition or how foods combine to make a complete nutritious meal, and the ability to prepare meals. Motivation reflects an individual's underlying desire to engage, which can be enhanced in a lot of different ways. Motivation can be conscious and intentional, but also habitual or instinctive. All of the factors outside of the individual's control fall into the category of opportunity. Opportunity can increase or reduce access through structural considerations like availability and affordability, and also social circumstances such as family acceptance, encouragement, and alignment with cultural traditions and norms. Manipulating any combination of these three factors has an influence on the behavior of the individual. The original COM-B model describes how interventions can target an individual's capability, opportunity, and motivation. to elevate the likelihood of productive behavior change. We characterize it as a threshold here in green, which, when crossed, produces the desired behavior change. Many food as medicine interventions focus on enabling or improving these individual factors in order to cross the threshold for behavior change. However, behavior change does not rely solely on individual effort. Systemic interventions can also lower the threshold for successful behavior change. Take, for example, a medically tailored meal, which is specified by a clinician, paid for by an insurer, prepared and delivered to the home, ready to eat. Effectively, it reduces the requirement for individual capabilities to nearly zero, except for the willingness to eat the meal provided to you. Medically tailored meals can thereby be quite effective at obviating the need for capability, motivation, or opportunity at the individual level, but they are, of course, expensive, which raises the question of where the cost effectiveness threshold lies. The evolution of the COM-B model This evolution of the COM-B model describes how such systemic interventions lower the threshold for successful behavior change, while individual interventions raise the capability and motivation of the individual. Take, for example, something relatively simple like nutrition education, a fairly common component in food as medicine interventions. It acts primarily on improving knowledge and skills of the individual, thereby raising their individual capability, sometimes enough to cross the threshold. There are less straightforward examples, like produce boxes, for example. While they might eliminate the need to select certain foods, thereby lowering the threshold for knowledge and skills necessary to choose food that's good for your condition, they also still require meal planning and prep, especially if the ingredients are unfamiliar to you, which may not be skills you already have, and therefore unintentionally raises the threshold for behavior change. On the opportunity front, if produce boxes are paid for and delivered, they effectively reduce the threshold for access to zero. Let's consider one last example, which is a combined family and caregiver education around cooking and nutrition. Importantly, it may have a very significant impact in opportunity by reducing family resistance to diet change, which is often a very significant barrier to healthier eating at a household level. But also, it may also invoke the caregiver instinct in the person preparing the meals, which then becomes a mechanism for increasing the individual's motivation. Which brings us to our third and final exercise for this session, which is for you to consider which elements of your study are individual interventions and which are systemic interventions, and what they target: capability, opportunity, or motivation. Again, this worksheet for this exercise is included in the assets for this session. Feel free to pause the recording to complete this exercise, and then resume the recording when you are ready. Welcome back. In case you didn't do the exercises alongside the session recording, here's a recap of the suggested exercises for reference. Again, the exercise worksheets are included alongside the assets with this webinar. This concludes this first webinar. I hope it's provoked you to think a little differently and at depth about your study. In the second webinar, which will be hosted by my colleague Natalie Prevet, she'll dig into journey mapping as a tool for better understanding user experience. Thank you for your engagement and have a great day.